speaking on cervical cancer?
Okay, good question. So if you look at all the cancers, in terms of incidence, that is the total number of cases that are actually out there in Kenya and also replicated in the world, as you have rightly pointed out, breast cancer is actually number 1, and then cervical cancer is number 2. However, in terms of deaths or causes of deaths, cervical cancer is actually number 1, and then breast cancer is number 2. So the main thing is, to go back to your question, why is it important for us to mark Cervical Cancer Awareness Month, especially in the month of January? Basically, like most cancers, and this one I'll stress it very much for cervical cancer, for 2 reasons. One, early diagnosis, and the second one is for prevention. So when you're talking about, let's go with the prevention, it's to educate those who are of the eligible age to actually go get the HPV vaccine. As I pointed out, the human papilloma virus is the main cause of cervical cancer. So they can go and get vaccinated against this. The second one is for early diagnosis. Now, cervical cancer is one of those that causes, is one of the cancers which tends to have what I'd call an aggressive nature. That is, once it is detected, can very quickly and very easily spread to other parts of the body. So the main thing here would be detect it early. If you detect it early, you can actually treat it early. So if you detect it early, screening is done. I need to point out, screening is actually done by various methods. The most common one, and I'll stress on this a lot, is what we call the HPV DNA. The HPV DNA is being piloted a lot in Kenya. So it's actually very easy to do. I think because of the viewers and all, I'll not go into the nitty-gritties of how you actually do it. But it's a self-test, can actually be done at home, and it can detect almost, I think, 30 or 40 strains of HPV virus, the strains, that is, which is actually very good. We have something called a pap smear, which is actually recommended for women. And then finally, not very common and probably used in low resource settings and not very much discouraged to use. That is what we call the visual inspection with acetic acid, what we call the VIV-LI. So visual inspection with acetic acid. When do we do these tests? For the women aged 21 to 30, they are actually encouraged to do a pap smear. And then between 30 to 45, you can do a pap smear, or you can do an HPV DNA. It is encouraged to do this every 3 years. After 65 years, it's not really very much necessary. However, if there are some extenuating circumstances, let's say you had abnormal cells which were screened earlier, you are immunocompromised, or some drugs which you are using at some point which can actually predispose you to this. So for those reasons, maybe you can be tested.
Is there a reason why the gap is 3 years where you're supposed to do, or the gap between you doing your first and perhaps your second test, or that regularity? Is there a reason why it's just 3 years?
Okay, you should actually be a medic. It's a good question. Yes, there is. As I pointed out, main thing is we want to get this cancer early, treat it early. Apart from the cancer, one thing you'll also note is there's a lot of financial toxicity. People actually spend a lot for the treatment of cancer. I know you have heard in the mainstream media, most people will be out there advocating and saying, we took our patients to India, we took our patients to probably America or Europe or other parts of the world just for the management of cancer. But if you actually detect it early, and that is why we are doing it after every 3 years, for anybody who is sexually active, you can actually be able to catch it early, and management at stage 1, where you can actually, what we call, so cancer has stages. So stage 1, stage 2, we call that early stage. So you can actually get it at that stage 1 or 2, then you can actually treat it early at a more cost-effective, I think I would say, or pocket-friendly numbers. Yes.
All right, now, you've talked of HPV infection, I believe, and what we are looking at, the theme of this year is actually, more about HPV vaccine, for a lot of awareness around HPV vaccine and what it is. And people may not really understand what the vaccine actually does or what it treats or how much effective it is when we're talking about cervical cancer. So if you could speak about that and just if it's a game changer for that matter.
Okay.
Yeah.
So the HPV vaccine, first of all, again, I need to point out it is a viral vaccine. There was a time we had COVID,
yeah.
and I like referring to COVID because it's one of those viruses that I think most of us can relate to, either was affected directly or indirectly with as a country, as a person, and all that. So the game changer there was vaccination. Remember, we were being told to get vaccinated for COVID.
Yeah.
So why am I relating this to the HPV? Because if the children or the girls aged 9 to 14 get vaccinated for HPV, basically what that means is the future generation will be covered for the HPV infection. Yeah. So there'll be reduced incidences of the HPV infection. So if you have reduced incidences of HPV infection, that means that there'll be less cervical cancer cases, and by so doing, we'll actually reverse that pyramid. We'll have either early stage or no staging of cervical cancer. Yeah. As I pointed out, it is the second most common cancer in Kenya, but it is the first cause of mortality or death in Kenya. So reverse that trend. Yes.
Wow. Now, perhaps you can take a look at the signs and symptoms, because first step of dealing with this kind of cancer is perhaps the knowledge. So if we could talk about the signs and symptoms, a lot of people may just be getting these feelings, but they think it's just a normal flu, or it's just small malaria. If we could take a look at those, what people need to be looking out for, especially women, what they need to be looking out for, so that they can take that step in going for screening.
Okay. So unfortunately, and I'll use the word unfortunately, we do not have clear-cut signs and symptoms for cervical cancer. However, we have what we call markers or indicators that can guide you towards telling you need to actually get screened. Yeah. I'll go with the first one because people tend to blur the lines here and there. Get screened after every 3 years. Just simple. Get screened after every 3 years. Yeah. What are the main signs and symptoms that you could actually be looking at for? I think the most common one is things like bleeding, especially for women who after menopause, which again could be an indicator of other diseases. Could be things like bleeding after sexual intercourse. Main factor again, I need to point out if a patient is actually immunocompromised. So if your patient is actually, let's say, immunocompromised, in this case we're talking about like an HIV positive client. So that woman, it is actually, HIV is a risk factor for cervical cancer. So those are the things that you actually look at. We have a drug. It's part of what I specialize in. It's called diethylstilbestrol. We just call it DES, DES. So patients who are actually on long-term use of this drug are actually supposed to also be screened regularly. But as far as signs and symptoms go, that is the much that is there, and you'll realize that they are actually blurry in terms of the boundaries. That's why shift back to what we were saying. Screen after every 3 years. Yeah.
Risk factors, we've talked about HIV and AIDS is one of the leading risk factors. Are there any other risk factors surrounding the cervical cancer?
Yes, there are. We will be talking, there are things like, apart from the HIV and AIDS, which is actually the most common, so that means that the patient is actually immunocompromised. Having multiple sexual partners is also a risk factor, considering the fact that now you are exposing yourself to various populations. So now your risk of actually getting cervical cancer is actually way high there. We're talking about drugs. I've mentioned the DES, the diethylstilbestrol is actually one. Then recently, and this is actually very interesting, smoking And secondary smoking has actually been found as a risk factor for cervical cancer. Then finally, this one is where we are going right now, and I'm really excited about this. We are going to genomics. Genomics basically means you treat as per the DNA or the RNA strand of the disease. So we are actually doing targeted therapy, including also for cervical cancer. And you could actually inherit. What am I saying this? I'm saying this because you can actually inherit. Despite all that, it could be familial. So from one generation to the other, you have actually that gene for getting cervical cancer. Yes.
The smoking one is actually interesting because I'm trying to see, how, where does it come in? Because, this is smoking, this is cervical cancer. So how is that a risk factor?
Now, thing about smoking is it has a lot of heavy metals. Most of these heavy metals tend to form what, okay, I'll take our viewers through a bit of a biology lesson.
Okay,
sorry for that. So most of these heavy metals will actually form things like free radicals, which will now cause the cells in the body to form, to cause an abnormal formation of cells in the body. Why am I saying this? I say, when we started, we said that the squamous cells are the most affected by cervical cancer. Now, those are also the easiest affected by the heavy metals and also smoking. So most of the people who actually smoke or secondary smoking find that most of them are the ones who are actually affected, because now the first pot of action where the abnormal cells will be formed, or one of the, not really the main one, but one of the main pots of action will be your squamous cells. Yes.
All right. Now, I'd like us to go through perhaps on the screening part, and you've got various stages of cancer. If we could be able to differentiate what stage 1 looks like and what stage 4 cancer looks like, because a lot of people normally discover it when it's too late, or they go for screening and they're told, you have stage this of cancer, and yet they say, I felt perfectly normal, I didn't have any problem. So if you could be able to get that difference of how does stage 1 looks like, how does stage 4 looks like of cervical cancer.
Okay.
Yeah.
So let's go with the stages. So I'll start with the first one. So the World Health Organization has classified cervical cancer into 4 stages. That is stage 1, stage 2, stage 3, stage 4. So for purposes of the population that is out there, I'd like to actually separate this into 2. That is early stage and late stage. Early stage being stage 1 and 2, and then late stage being stage 3 and stage 4. The reason why I'm doing, I would propose that is for easy understanding of the various stages. Again, we will break down the stage 1 and 2 if it permits. So early stage basically means that this is cancer that has spread but is still confined to just the cervix. So just the cervix itself. Initially in Kenya, and I think it's still being done in some counties, you would find like the woman would be told they wanted to inspect her vaginal area. So like if the healthcare practitioner was to put some acetic acid around there, they would actually see some colorings for the cells. So it's very easy to actually identify them. So basically for early stage, it's just confined to the cervix. Between stage 2 and 3 somewhere, then it starts moving to other organs. So stage 3, you will find that probably it has moved from just the cervix, it has gone to the endometrium, the uterus, probably even the ovaries. So that is now stage, that is now late stage. If a patient was to go and be screened, and then after that they are told to actually go for some form of, like let's say a CT scan or an MRI, and then you find like there is evidence of the disease having progressed to either things like either the liver, the most common ones are usually the liver, the bones. Then probably now we have said now that is stage 4 because it has spread from just where it was confined, that is the cervix for early stage, to stage 4 where now it has gone to other parts of the body. And that basically is also what guides the management of the cancer.
Yeah.
Yes.
You know, you said from stage 2 to 3, you know, the cancer basically moves to other organs of the body, including the uterus and the ovary. And does that still, you know, call it, you know, cervical cancer? Does the name still stick, or you know, you get instances where the cancer moves to another part of the body, and then it's called a different name? Is it still the same?
Good question. It is still the same. So most cancers tend to do what we call metastasize. Metastasize is basically the movement. When you're told that you have mets or metastasis, it means that the cancer has actually moved. Like in this case, we're talking about the cervix, has moved from the cervix, but we have evidence of the same cancer in what we call, like, let's say, the liver or the bones or the ovary. So for viewers out there, when it is in the cervix and confined in the cervix, then there is no mets there. But when it has spread out, then we say that it has metastasized. Now, once it has metastasized, that is now late stage of cancer. Yes.
All right. So do we have cases where once one person is treated to multiple cancers in the body?
Yeah, I have actually met some. Not related to this, but we had a patient who had esophageal cancer and also prostate cancer. So these two, now the main source where the cancer originates from, we call it the primary. So primary means where it originated from. If it is cervical cancer and it started in the cervix, then it is cervical cancer as the primary with the liver mets. So you can have liver which has lesions of cancer because of the cervix, so we call it liver mets. So now that is your secondary. Can you have two primaries whereby you have cervical cancer, for example, and then by some one way or another you also have things like esophageal cancer? Very possible. Again, think about it probably like, and this is just an hypothesis, let's say you're a smoker. Very easily can get esophageal cancer because of smoking, but the same smoking will also cause cervical cancer. So the esophagus was not the esophageal cancer was not caused because of the cervix, and vice versa. Both of them were caused because of the smoking. So both of them are primaries. So you have two primaries. Yeah. Yes.
All right. Now, we've looked at, you know, the indicators, because you've said there's no clear-cut symptom that this is cervical cancer. I'd love us to now take a look at the treatment part of it, because what the stories you'd hear from cancer patient is that, you know, the drugs are too expensive, they're too much, the diet changes as well. So what is the treatment that comes with the diagnosis of cervical cancer?
Okay, good question. I'll start with the first one. So treatment of cervical cancer, probably you have your early stage and then you have your late stage. So for your early stage, the definitive diagnosis, of course, is through the pap smear. That's how we'll actually confirm that you have cervical cancer. So how do you treat it? There are like three methods for early stage cancer. So you have something we call LEAP. LEAP is an acronym for loop electrosurgical excision procedure. We have thermoablation, and also we have something called cryotherapy. So those are three methods which are actually done, very cheap, cost effective, and also very effective in the management of early stage cancer. Then we move to the late stage cancer. So for late stage cancer, now the patient will have gone and seen somebody, preferably we call gyno-oncologist and also a radio-oncologist. So treatment can include three forms, no, 4 forms. I'll go with 4 forms, the most common. The 3 most common which are actually there is radiotherapy, whereby somebody will be told, if I may use the local lingo, because that is what most of our patients usually say, nilienda kuchomwa. It is not really burning per se, but yeah. So they actually go for radiotherapy. The second one is surgery, whereby you can actually remove the uterus and most of the affected cells. And then the third one would be chemotherapy. Surgery is done independently, but chemotherapy and radiotherapy can be done either concurrently or can be done sequentially. That is, you do your chemotherapy, then you go for your radio, or done concurrently. Now, the fourth one, which is out there and is really coming, is targeted therapy. I know a few of our national referral hospitals are actually working very hard towards actually scaling up in regards to this, and some module that is coming up very well.
Yeah. On surgery, you basically said it's the removing of the cells or the affected area. Does it guarantee that the cancer will go away for good?
No. Even we need to point this out. When we're talking about the causes, if a patient probably went through the treatment and all that, and then you did the surgery and probably removed the affected cells, can you miss some, let's say, probably a metastasis? That means a growth of the cell somewhere else. For sure, because probably 1, 2, 3, 10 cells would have maybe moved to another place, probably the liver, your ovaries, or any other part of the body. That is one possibility. The other possibility is probably, and unfortunately this could be possible, the surgeon does not get what we call clear margins. That is, they are not able to excise the whole affected area. So that small lump that is there can actually grow into something, that small grain of cervical cancer that is there can actually grow to something that is bigger. So is it possible? Yes. So even if a patient had cervical cancer and they were treated and they became, were told they had gone into remission, that means they were cancer free, they're still advised, go get screened. Yes.
Yeah. Also, is it, you know, you've mentioned 4 ways of treatment. There's the radiotherapy, surgery, chemotherapy, and targeted therapy. Is it necessarily possible that a patient has to go through all these 4 stages, or they can do maybe 2 concurrently and that's it, or do they have to go all through, or through all 4 of them if necessary?
Wow, good question. Can go through all? It's actually a possibility.
Yeah.
The patient can go through all the sessions. Those are the 4 modules of treatment. Can actually go through 2. The most common ones are usually chemotherapy and radiotherapy, and surgery. So some can actually do just the surgery and the chemotherapy. So when a patient has like late stage cancer, that means it has moved to the liver, it has moved to various parts of the body. The main aim there most of the time would be things like chemotherapy. Why we are doing chemotherapy? Because it's systemic, can go through all parts of the body and kill any cancer cells that are there. However, if it is just confined and your clinician or your healthcare practitioner has confirmed that it's just confined to the cervix, then it's actually easy to just do surgery and probably a bit of chemo radio. But again, resource settings, some patients might be forced to actually go for the targeted because of a strain that is what we call a wild type. Wild type is those aggressive ones that can actually spread to other parts. So we want a specific targeted treatment for that kind of strain.
Yeah.
Yes.
All right. And also at the center of it is on matters diet. And you'd hear patients say they've had to let go of this a lot of times. They've had to adapt this sort of food or this sort of diet. How much does diet play a role as well in the treatment and care for cancer, particularly cervical cancer, as well as what changes in the diet for patients?
So by patients, it means somebody who has actually been already confirmed they have cervical cancer.
Yes.
Like most cancers, unfortunately for cervical cancer, it tends to be associated in the initial stages before being treated, usually associated with a lot of what we call pervaginal bleeding, or a lot of bleeding in the part of the lady or the woman. So the main thing that we usually focus on in terms of diet here would be probably take more fluids, eat more in terms of your green leafy vegetables and red fruits and anything that actually what we'd call a blood builder or something that can help increase on your blood content. We advise our patients to avoid processed foods, sugary foods. Again, those are also other things that we need to look into. And then for patients who are undergoing treatment, and this is actually very common, if the patient realizes that they are actually vomiting a lot or they are unable to tolerate foods, we usually tell them eat small portions. And also additionally, this is just a word of encouragement out there, you are not alone. A lot of patients actually go through this. The only thing is try as much as possible, because I'm sure most of these drugs make them to not feel like eating. The appetite tends to disappear.
Yeah.
So probably encourage each other to eat small portions so that it can actually build up, so that what we call their hemoglobin levels and their blood levels can actually be good enough to withstand the treatment, and also to help them in terms of apologies for that, their normal activities of body functions.
Yeah.
Yes.
All right, we'll get to the SHIF a bit, the Social Health Insurance Fund, which the CS for Health says it's a game changer, particularly for treating critical illnesses. But there's somebody who must be watching and is inquiring, is there a way they can avoid, getting cervical cancer, or how do they lower their chances of getting cervical cancer?
So, like I'd said earlier, the game changer is actually prevention. It is cheap, it is affordable, it is accessible. So how do you lower your chances? Get screened. Every 3 years, get screened. That would be actually the main one. If you come from a family, let's say your mother and somebody within your bloodline, or there is a high incidence of cervical cancer within your family, then this is something that you need to look out for and go get screened. For the women out there, or for the young girls between 9 to 14, they need to get the HPV vaccine. That is actually very important for the next generation. For the men out there, the husbands out there, make sure that your wife gets screened every 3 years. And if you have a girl who is school going, that is 9 to around 14, let them get the HPV vaccine. Yeah. And probably that would save this generation and the next generation.
Yeah.
Yes.
Also, there's a question of sexual activities as well. Perhaps the 20-year-old who is not sexually active, can they access the HPV vaccine?
Well, the answer would be they are not sexually active. Probably, I would say they get screened first, and then preferably with the pap smear. If it is negative, then yes, they can get the HPV vaccine. However, at the advice of the healthcare practitioner, because the HPV vaccine is what we call a live vaccine. You're actually getting the HPV itself. So how your body withstands that would be something that you need to address. But yes, if you are not sexually active and your pap smear is actually negative, then yes, you can get. The reason why we are doing 9 to 14, I think most of the institutions, and actually also Kenya as a country, is because we are going with the assumption that at that age, most of our school-going or young girls are not sexually active. Yes. All
right. Now, the Social Health Insurance Fund basically has a more preventive approach, contrary to curative approach, and it has introduced a new, I'd call it insurance, where there's the critical illnesses that are being covered as well, contrary to what NHIF had before. And one of the biggest, crippling factor to treating cervical cancer, or even not just cervical cancer, but any cancer, is just the expenses that come with it, and how families have to struggle to pay for treatment, or even go for chemotherapy or radiotherapy. So how much important was it for critical illnesses to be included in the SHIF, so that everyone is able to get medical services with just that card, and that can even work on cancer as well?
Now, as you have actually put it, the Social Health Insurance Fund, for purpose of this discussion, I think, if you don't mind, I'll call it the SHIF. Most people call it the SHIF because of SHIF.
Yeah.
It's actually a game changer. We have a program in Kenya called the National Cancer Control Program, headed by a lady called Dr. Mary Nyangasi. I think recently she said that one of the things, apart from just having the disease itself, that is cancer, it also causes another disease which we call financial toxicity, whereby the mwananchi actually spends a lot of money out of pocket for this. So how is this important? I'll actually give a bit of a background of where I've actually worked in some counties within Kenya. Do you know people actually sell goats and chicken just to go to hospital for chemotherapy or radiotherapy or surgery? People have actually sold land for this. So having it very high in the priorities basically means that the common mwananchi, apart from being able to actually access these services, as much as our government right now is doing a lot in terms of preventive, they have actually done something in terms of trying to make healthcare accessible for the common mwananchi and those who cannot afford it. So it is actually very high on the agenda. The idea here being that the patient who has actually subscribed to the Social Health Insurance Fund is actually able to access chemotherapy, radiotherapy, and I think some level of surgery through that card. However, I need to point out a few things. One is probably the financing. Surgery would cost almost $1 million. I know a lot of people have WhatsApp groups whereby they contribute towards this. Radiotherapy by itself in terms of transportation and also access. If I'm not wrong, I think we have government facilitated around 4 radiotherapy machines in Kenya. That's very small. I think 4 to 6 there. No, just 4 or 6 somewhere there. I think if you go with the 3 national referral hospitals and I think 2 others, I think there will be 5 or 6. So again, look at the cost, the waiting time, the turnaround time between the patient going and accessing the care and all that. And then they have also scaled up in terms of the chemotherapy centers. We have a lot of, I think by my last count, we had 17 Empower clinics. That is clinics that were opened by the county first ladies for management of cancer. So that has also helped augment access of care through the Social Health Insurance Fund for those who will be having it in these facilities. But the main thing here would be probably for me, and I'll still stress this a lot, is the preventive part whereby you actually go for early screening and early diagnosis. But again, having that high on the agenda is actually something that I'll probably congratulate the current government for. That is.
All right, so as we almost wrap this conversation up, there are so many myths and misconceptions that go around cancer, and because it's cervical cancer, we'll stick to just the cervical cancer. The myths and misconceptions around it, people, you've heard of people say when you're having sexual relations with this kind of woman, you're actually likely, for the man, you're likely to get prostate cancer. So what are some of these, holes and gaps that people poke into that are just not factual at all?
We are Africans. The first one we'll go with is witchcraft. I've had several stories, or we have witnessed several stories, some documented, some undocumented, but we have cases where people tell you there is witchcraft. I've had people who have said this is spiritual. That means in terms of spiritual welfare, somebody is coming to affect you. I've had people who have actually come and said it is something in regards to food poisoning. Some of them even come and, not really, like poison in their food, not really food poisoning. I think poison in their food would make more sense. We have had people who come and have their own myths or traditions and all that. What we usually tell them, most of our patients, as much as we have tried to do the early diagnosis and we have confirmed it is cancer, the main thing is actually talk them through the journey, explain to them how this cancer is, and then which one of the things that we do in most of our facilities and I'd really encourage is actually work with your patient through what we call the treatment plan. This is what we will do. We will give you chemotherapy, we will do radiotherapy. When we do the chemotherapy or the radiotherapy, probably you will get some level of nausea, probably your appetite will go away, probably, those kind of things. So that the patient knows my appetite will go away, probably I'll be vomiting. So if I grow thin, it's because of the treatment that I'm getting, not really because of the witchcraft or all that is out there. We really encourage our patients and those who want, like from where I work, for our patients to, if you feel like it is spiritual, we invite the pastors. They actually come to the hospital. What we usually say to them is, rather than just pray for that one patient because they're the ones who brought you to the hospital for explaining to this, pray for all the patients who are there that day. And we have had that. We have psychosocial group meetings whereby those patients who have actually gone through the treatment and are in remission, that means they were tested and they were found to not have cancer, they come to those new patients who are now new, who have been diagnosed, and they talk to them, they tell them their journey, and it helps demystify most of these myths and misconceptions that are out there.
Yeah.
Yes.
All right. So as we wrap it up, Dr. I'll give you the last opportunity for you to speak also on the positive stories that also come out of cancer, where somebody says, you know, the cancer of the body is completely gone and they're completely cured of cancer, so it is possible. So as we wrap it up, perhaps speak on that as well.
Okay. So we have success stories in cancer. And one of the things that we need to do, and thank you for giving us this platform, is to actually shout it out, bring it out to the world. So we have patients, like where I work, for purposes of privacy, I won't really disclose names. We have patients. We have like a lady who had cervical cancer. She was 36 years old, had what was initially diagnosed as a stage 3A, that's almost a late stage cervical cancer. One daughter, widowed, the husband passed away, but through the management that we had, she actually became cancer-free. She's back to her work. She's actually a tailor. She's a tailor, and also she does mitumba. Mitumba, she sells mitumba. So she's actually able to provide for her one girl who is out there, and she's actually one of our motivational speakers. She'll actually come talk to the new patients. We have another man whose wife was a breast cancer survivor. I know I'm bringing it up. It's not part of cervical cancer, but if you'll allow me. Why am I talking about a man who had a wife who had breast cancer? Because the wife was diagnosed with breast cancer in 1998. She died in the year 2022. Again, if you look at it, the survival curve, you'll realize that she actually lived for a very long time. That would be 24 years? 24 years, yeah. So you see, you extended somebody's life, you extended somebody's quality of life. They were able to actually stay with their children. Like this lady was actually even able to see her grandchildren because of the quality of care she actually got because of the management of the cancer. For me, that's a success story. She's dead, we agree, but that's a success story. Why am I saying this? Surprisingly, this lady used to make what we call breast prosthesis. So you'll realize that most patients who have breast cancer, they get their breasts, they get what we call a mastectomy, like the removal of the lump and the breast and all that. So she used to do prosthetic breasts for sale, and that was her way of giving back to the community. So she'd actually sell them at a cheaper rate and also be able to make her ends meet while also advocating for the same. For me, those are success stories. I would probably go and give you 1,001 of them, but we have psychosocial groups, and I know because of time, probably I'll leave it there. But I think we need to increase our platform. I'll confirm that. I think it's in December. December we celebrate the cancer survivors. Unfortunately, I don't think, and I'll apologize for that, I don't think we really shout about that so much. It's one of the things we need to shout about, because it gives hope to the people who are out there. It gives hope to the generation that is there. It also shows, as a healthcare worker, the good work that we are actually doing that needs to be also applauded. Yeah.
All right. Thank you so much, Dr. Orange Gavin, an oncology coordinator, for coming this morning to share more about cervical cancer awareness, wellness, and care as well. The statistics, of course, you know, are shouting the need for having this conversation. 16.8 million women aged 15 years and above are at risk of developing cancer. And as Dr. has said, between ages 9 and 14, that is a young girl that can go and access the HPV vaccine. As well as every year we have about 5,236 women that are diagnosed with cervical cancer, and out of them 3,211 die from the disease. So it all goes back to the basics: prevention. You need to go to for screening, regular screening for that matter, so that they're able to, you know, identify it as early as possible, and also for you to know, you know, the status you are, or your health status, and this is done every 3 years. So it is important for you to be able to know that as well. So that is the conversation that we've had this morning. In case you've missed this broadcast, you can rewatch it once again across our social media platforms. Even as we mark the end of January, in just a few days, it will be the end of Cervical Cancer Awareness Month. But the conversation does not have to stop just because the Cancer Awareness Month is over. It is always something that needs to keep going. My name is Cynthia Nanjala. Thank you for watching Morning Live. Have yourselves a fantastic day.